So now it's my great pleasure to introduce Craig Samitt, President and CEO of Blue Cross Blue Shield of Minnesota. And Craig is an internal medicine physician by training and has extensive experience across multiple sectors within the healthcare industry. He is a nationally recognized expert and thought leader on healthcare delivery and policy. He has previously served in many senior executive roles and as a commissioner of the Medicare Payment Advisory Commission. Craig is committed to positively impacting all the drivers of health outcomes to build stronger communities. And I can tell you he is someone who makes change happen. We're so pleased to have him with us today to share his insights. Please join me in welcoming Craig to the podium.
Thank you so much, Nancy. Afternoon, everyone. How are you? I'm pleased to actually represent the fine state of Minnesota. I'd welcome you to come visit. I'd hurry up because it only just goes downhill from here. But come and visit us. It's a beautiful place. I want to start with where Curtis ended. The reason why I say I'm representing the fine state of Minnesota is to truly address the issues of health inequities or social determinants of health really takes a village. We can't solve it on our own. Hospitals can't, doctors can't, the state can't. The reality is that we need to do it together. We need to stand up shoulder to shoulder to address what's actually really getting in the way of what our mission warrants, which is to delivering better health for the communities that we serve. Minnesota is a special place for those of you who know. I think the state has often been, and it's why I went there, has often been a vanguard of transformation and of pursuit of a better way. Long before the ACA was passed, I think there was a significant focus toward value-based transformation in Minnesota and in other states. I was in Wisconsin at the time. The upper Midwest had that pretty prevalently. But Minnesota is also a state that very much focuses on public-private partnerships and really not just talking the talk, but standing up and walking the walk, and truly taking action to address things that we see that get in the way of supporting the health of all Minnesotans. So before I actually talk about social determinants, I want to highlight the fact that Minnesota's been here before. And I actually want to go back 25 years. For those of you who remember, in 1994, Blue Cross Blue Shield of Minnesota and the state of Minnesota filed an unprecedented lawsuit against big tobacco. That at the time, we thought our case was straightforward and that we needed to collectively address what was getting in the way of community health. Blue Cross Blue Shield of Minnesota and the state of Minnesota prevailed in that suit and settled with the tobacco companies to really put in place a foundation that would address and resolve and prevent the ravages of smoking in the state of Minnesota. We created an organization called the Center for Prevention as a result of that settlement that has essentially focused for now over a decade on health and wellness and prevention, with the reality being that we'd like to find other examples like tobacco cessation that will improve the health of the communities that we serve. So the reason why I wanted to come and why this is so relevant to the work we're doing in Minnesota is that the reality, I would say, is that the healthcare industry does not live this long-standing premise that an ounce of prevention is worth a pound of cure. If we talk honestly and think realistically about our industry, we profit off of sickness, or most stakeholders in our industry profit off of sickness. And what happens if we actually shift from a profitability of sickness to a profitability of wellness and live this notion that an ounce of prevention is worth a pound of cure. I had a little bit too much time on my hands, so I actually did the math. So obviously 16 ounces in a pound. And so the material calculation here is that if we put $10 million into food insecurity or loneliness or homelessness, or frankly, true wellness and prevention and gap closure, we should save $160 million in unnecessary, unwarranted, or preventable sickness and the complications that come from sickness. So from my point of view, the issue of social determinants of health, health inequities, wellness and prevention all fall into the ounce. And the desire for organizations like ours, especially as one of the stakeholders that frankly benefits not when people are sick, but when people are well, that this is an area where organizations like ours very much need to invest our time and energy. As a result of that, our organization has realized that we need to reinvent ourselves. We just actually finalized and presented our new strategic plan to our board. And the reality is our strategy is all about becoming something completely different than what we were. Health plans are traditionally known as claims companies or network companies. Well, maybe we actually need to be in the disease curing business or the opioid or other epidemic prevention or resolution business, or in the retail business, or in the customer adherence and behavior change business, or in the social determinants of health business, or in the care delivery business, or in the data and technology business. Maybe the approach that we've taken hasn't really achieved the result that we want to achieve. We're gonna come back, I think, in the questions regarding opioid because we've got a lot more to say and a lot more evidence to share, but I actually want to concentrate the remainder of my remarks on social determinants of health. What we learned, we actually began to address the opioid epidemic before it was actually being more broadly discussed throughout the community. And we actually established something called the High Complexity Case Unit because we realized that individuals with complex illness, whether it was addiction or multiple chronic diseases, often had needs that went beyond the clinical needs. Don mentioned this beautifully. It was much more than just the 20% of care that happens in the clinical world. It's the 50% of care that happens in the social related world. And we realized that needs went far more broadly than just our day jobs, and that we needed to expand and reinvent our day jobs. So somewhat similar to Curtis, I wanted to share some examples of how when we step into a new lane and think about social isolation or food insecurity or transportation, what impact do we have on people's lives? So I'll show you a sample of our work with our HCCU.
I'm a miracle. I can see, I can walk, but I feel great today. Excited to meet Miss Marcy. She was my angel. She didn't give me no medication, but her medicine was talking.
Today I'm going to get an opportunity to meet Antonio, who is a member that I have been working with for a little bit over a year in the High Complexity Case Unit, the HICU department. Hi Antonio, this is Marcy, the nurse with Blue Cross Blue Shield of Minnesota. How are you doing? We get the most complex members and we look at health diagnoses, but also things that might impact a social situation, if there's any barriers that they're facing, like with housing or food insecurity. So it's really a holistic approach to case management. Yeah, definitely gonna need some help on that. Antonio triggered to me in the summer of 2017 after he had suffered a stroke.
I have survived. I didn't have one stroke, I have 4.
Part of the lingering effect that he was having from the stroke at that time was it was affecting his eyesight. He could not read the medication bottles.
When I was blind, I thought, I don't know what I was going to do. I was going crazy. I say, how I'm going to cook, how I'm going to do this, how I'm going to get medication. I said, Miss Marcy, I need your help.
I called out to the nursing agency. They were planning to get out there in a day or two, and I talked to them and let them know that he really needs somebody out there today to get these set up for him. And they got out there that evening.
From there, I knew I had to make a lot of changes in my life. Her talking got me up, give me the right direction to be up.
He's very appreciative of Blue Cross. He's appreciative of me as the nurse reaching out to him. He has expressed that it's been an asset to his life and his healthcare plan. I am looking forward to meeting him and just putting a face with the name and the gentleman and the relationship that we've had for the last year.
Miss Marcy,
Antonio.
let me
Oh, it's so nice to
nice
meet
to
you.
meet you. No, believe me.
Gosh.
This is great.
He's trying very hard to make positive changes in his health to hopefully improve it in the future.
I don't want to be sick, believe me, guys. I don't. I want to say, Miss Marcy, I'm good. I feel better.
People after a negative health, occurrence for, a month or two might be like, I'm making the changes, or, I'm going on the new diet. But it's been well over a year, and he's done really well to maintain the changes that he's made.
My health has been improved a lot. I mean, like I say, I'm a miracle. I'm grateful.
So I remember when I was in Wisconsin, looking somewhat jealously at Minnesota across the state line, because I knew that the quality of care in Minnesota has historically all been very high. What was remarkable when I actually got to Minnesota and looked under the covers is while we are one of the healthiest states in the nation on average, we're home to some of the worst health disparities and health inequities in the nation. This is not Minnesota, this is Sao Paulo, Brazil, but picked the image to make the point. I think Don's was very effective with the subway map, but we struggle with the same thing. Within a 3-mile stretch within our capital city of St. Paul, there's a 13-year difference in lifespan. So race, income, gender, social circumstance drives some significant variations in the equity of the care that we provide, and our focus is on stamping out health inequities. In Minnesota, African American and American Indian babies die in the first year of life at twice the rate as white babies in the state. So we feel, just as Minnesota always does, that we need to stand up and take action and do something quite differently than we've ever done before. As I said, it takes a village, and so because it takes a village, I wanted to end by sharing with you 4 different simultaneous approaches that we're taking to try to pilot and resolve social determinants of health. Because frankly, we don't know which one is going to be most effective, so we're seeking to try all of them. So let me start here. So this is Staples, Minnesota. Lakewood Health System is a small community hospital that began to see that they were having a surge, even to Don's point, of emergency room visits. And they found that a significant percentage of them were because people were hungry. And they knew that they would actually get a good, healthy meal for themselves and their family if they came to the ER, so they came to the ER. So Lakewood Health System created what they called a food pharmacy within a F-A-R-M pharmacy, and every month began to grow and distribute 2 tons of food for their community as a way to keep them healthy and keep them out of the emergency room and keep them at home. We actually recognized Lakewood Health System with a Trailblazer Award because what we really wanted is for this innovation to spread throughout the state. You know, my long-held belief is that we don't have an innovation problem in healthcare, we have an imitation problem in healthcare. We constantly hear very good examples of great stuff that folks are trying. Why is it that we don't actually extend that everywhere? So it created our first innovation, which is we began to talk to consortiums of health plans and hospitals in the state. There's a group called IHCM, which you may have heard of, which is a consortium of nearly every health system and every health plan in Minnesota. And our first intervention is we said, what if we work together to solve a single social determinant of health, like food insecurity? Health plans and health systems should be interfacing with or touching nearly every community member in Minnesota. So what if we collectively took it upon ourselves in combination with the state to address a single social determinant, and can we move the needle? Somewhat similar to what Curtis is doing, but even more broadly with other partners. It's not just about Blue, it's about everyone, especially those that we don't necessarily insure. This is the statewide effort. So this is the Staples, Minnesota story. The next story that I want to talk about is in Willmar. Willmar is a small rural city of just 20,000 people, about 100 miles west of Minneapolis. And over the last several decades, Willmar has become increasingly racially diverse, with growing communities of Latino and Somali immigrants. And Willmar couldn't look any different today than it looked even 10 years ago. So we actually came in, and what's special about Willmar is that most of Willmar is insured by Blue Cross Blue Shield of Minnesota. So in many respects, we are accountable for and committed to the health of nearly the entire town. So our focus in Willmar is, what if instead of solving for a single social determinant, we solved for all the social determinants? And we said whether it's social isolation or housing insecurity or affordability or food insecurity, let's work with this community and create resources, not as a directive, not to the community, but for the community, because we wanted to determine whether this notion is true, that an ounce of prevention is worth a pound of cure. So take a look at some of the feedback from our work in Willmar.
If people don't feel safe with where they're at, they don't feel comfortable with the people that they're around, they're not going to seek the help that they need. Blue Cross Blue Shield came to the table. They started looking at how can we partner and make the community stronger? How is the community healthy together? When this idea was first pitched to me, I thought, yeah, right. An insurance company is going to come to Willmar, Minnesota, invest time, resources, and talent, and they're going to let us drive the bus? I don't think so. But that's exactly what happened.
So our third intervention is about getting into the care delivery business. We've talked at Blue Cross Minnesota about becoming the change we want to see. If we live in a world that profits off of sickness, and we stay in our lane and think just like clinicians, where all that our responsibility is paying claims, having doctors and networks, and curing disease, then we're not really playing a part in reinventing care delivery as it should be. We announced just a couple of months ago a partnership with North Memorial Health in Minnesota, which is a community health system that has a significant ambulatory presence. Our focus here is reinventing care delivery. What if the focus of care was not in doctor's offices, and not in hospitals, and not in ambulatory surgery centers, but it was in the communities, in the home, online? What if we didn't think of it as internists, we thought of it as upstreamists or residentialists, or I'm big on creating new specialties that don't exist. But should we reinvent care delivery that is inclusive and integrates behavioral health, social determinants, wellness and prevention, not just the traditional model as we know it? So more to come as we continue to build out these reinvented care delivery models, but that is our third approach. And then finally, I wanted to come back to the Blue Cross Blue Shield of Minnesota team. And this slide has two purposes. One, just as Curtis described, nearly every one of our associates gets involved to some degree in social efforts, community efforts. This is one of our teams that was actually building a house for Habitat for Humanity, but we also have a community giving garden. We give back as part of our daily week, not just on the weekends, to help the social health of the community. And this isn't the fourth example that I want to give you. The fourth example I want to give you is we wondered whether before we can start to solve for social determinants throughout the state of Minnesota, we have to figure out whether we have problems with our own associates. So we thought we likely didn't. We're one of the larger corporations in Minnesota. Our folks are very well paid. We would be immune from social determinants, right? Or that is at least the philosophy perhaps that corporate America has. So we actually surveyed our people, and we asked about all the things that we normally do to screen other patients. You would be heartbroken if you saw the results that we saw about our own people that don't know if they can stay in their home, don't know where their next meal is going to come from, or the next meal for their children, or frankly, even some examples of our own associates that could not afford Blue Cross and Blue Shield of Minnesota insurance. So our fourth intervention is to look at, address, and eliminate social determinants and health inequities for our own people. So I want to end with where I started, is it takes a village. Just because we're a health plan doesn't mean like we need to act like one, always. We can be a catalyst for change, and we must be a catalyst for change if we want to make healthcare more sustainable. Thank you very much.